specialist clinical lecturer at Cebu Doctors University College of Medicine. She holds an MD from Cebu Doctors University College, is a diplomat of the Philippine College of Lifestyle Medicine, and has a BS in Public Health Sciences from the University of California, Irvine. As the Municipal Health Officer in Bantayan, Cebu, she was one of the early implementers of utilizing artificial intelligence in the Philippines for TB diagnosis. Her work has significantly improved early detection and access to care in remote island communities, advancing health equity in the fight against TB. She currently serves as TB program consultant for several government units and is leading the Philippine TB caucus to advocate for TB patients and survivors. She will be talking about, as you can imagine, about TB and artificial intelligence. And we're really lucky that it was that Samantha needed to be in Singapore for other reasons, and very kindly accepted the invitation to giving this seminar. So thank you, Samantha, over to you.
Thank you. Good afternoon, everyone. My name is Dr. Samantha Tinsay, and my talk today is about leveraging artificial intelligence for TB diagnosis in remote island communities, equity, gaps, and gains. Next slide. I have no conflict of interest to declare. Sorry. That's okay. Okay. Sorry. That's okay. So this is Bantayan Island. It's a rural island municipality in the northernmost tip of Cebu province. It takes about 3 to 4 hours to drive to Hagnaya Port, and about 1 to 2 hours by ferry. So a total of 5 to 7 hours to reach this beautiful island. But starting 2 weeks from now, there will be a flight from Cebu City to the island, which will take 30 minutes. So that saves us a lot of time. So this beautiful island paradise has 25 barangays or communities in this one island municipality. Next slide, please. So Bantayan Island, I was only supposed to stay here for 6 months, but 6 months ended up into 4 years because of this beautiful island paradise, as you see here. But not everything is perfect in paradise. Next slide. So these are some photos I took of my patients with their consent. I just wanted to showcase the access to care in Bantayan Island, how there is limited healthcare and resources when I started in 2021. So you can see the 2 pictures here on the young women. These are teenage mothers. The one on the left is 17 years old, and the one on the right, very right side, is 14 years old. So there was a lot of issues with healthcare access inequity and in the island. Next slide, please. These are some of the cases that we see on the island, since it takes about 6 to 7 hours to reach a major healthcare center. There are very limited specialists and also severe cases that we can see there. Next slide. And some other cases that are common and that I see in the island as well. We have the one on the very left with the indentation, a coconut fell on his head. And we see cleft palate and some other diabetic foot. These are some common cases we see there. Next slide, please. So this is our transportation in the island. So as you can see, we are dependent on the high tides and the low tide. If it is low tide, we cannot reach the other islets, but if it's high tide, we can go ahead. And sometimes it doesn't even matter what time the high tide is, as long as we can reach the other islets to deliver care to the people. So sometimes we take a smaller boat called a bote-bote, as you can see in the top right picture there. You just have to pray that you can balance properly on that small boat, or else you'll tip over and you have to walk, like the one on the bottom right slide there. You have to walk 1 kilometer, sometimes more, in ankle deep waters. Next slide, please. I just wanted to show this picture because, as I said before, we are dependent on the tides. And this was the first day of one of our medical officers. At 3 a.m., we ventured off into another islet to deliver health services. And this was something that is common, actually, that we do on the island. Next slide, please. So sometimes you have to go where the tide goes. So if it's at 3 in the morning where the high tide is, then that means you have to be on the boat and ready to go at 3 in the morning to deliver health services. So before 2022, there were no point of care testing or diagnostic centers in Bantayan Island. So people would sometimes have to travel hours and spend all their wages just to get health services. So what we did to bridge that gap was to deliver home service care, or we would do home visits to our most severe patients, such as our patients with diabetic foot, patients with tuberculosis, patients with disabilities, etc. Next slide, please. So what is health equity and why is it important to us today? Health equity doesn't mean that everyone gets the same treatment. It means you receive treatment based on where you are. So in Bantayan Island, our main issue is transportation. Our main issue is a lack of specialists. So I'll discuss later on how artificial intelligence and point of care testing can help bridge the gap and help deliver equitable access to care. Next slide. So these are the 3 tools that we used under the USAID funded Introducing New Tools program. So this was back in September 2022. And in the beginning, my staff at Bantayan Rural Health Unit were actually kind of scared and kind of nervous about using these tools because this was given to us during the start of typhoon season in the Philippines. And USAID told us you have to check all 25 barangays and you have to do active case finding for TB, knowing that there might be a risk of us encountering weather disturbances because we only had 2 months to actively use the tools. So we had 3 tools, the ultra portable X-ray, as you see on the left, artificial intelligence in the middle with CAD4TB under Delft Technologies, and then you have the TrueNat machine or a mobile molecular sputum test that we also used as a one-stop shop. Next slide, please. So this was our algorithm that we used for our active case finding. So as you can see there, we would do the screening with the ultra portable X-ray. If there was an abnormal X-ray on the CAD4TB or the AI, then we would send this to a radiologist for further review. And at the same time, we will also take a sputum test with the TrueNat so that we can get on-the-spot confirmation for bacteriologically confirmed TB, as well as on-the-spot HIV, provider-initiated counseling and treatment, as well as treatment on the spot for drug-susceptible tuberculosis. So for a drug-resistant tuberculosis, this would be referred to a higher facility. Next slide. So as you can see here, I just wanted to showcase the treatment access or the diagnostic access in Bantayan Island from 2019 to 2025. So as you can see, 2019, 2020, 2021, we were only screening around 200 patients out of 89,000 a year. That is very, very small for a population that is almost 100,000 today. So screening 200 out of 89,000, you're actually missing a lot of cases of tuberculosis and other respiratory infections. And in 2022, we saw really a significant increase in the screening because of these tools, especially the use of AI. As you can see, we jumped from 200 screened in 2021 to 2,506 screened in 2022. That is such a significant jump. And you can see the cases also increased at the time. Because if you're finding cases or you're screening people, then you're finding more cases of TB. In 2023, we were given the chance to use the tools again for 7 months. So you can see we were still retaining that 2,000 screened with 341 confirmed cases. 2024, we were able to use the tools for 8 months, which significantly increased our patients screened and also confirmed cases. And this year, we were finally gifted ultra portable X-ray with AI by the Global Fund, which we started using in March of this year and continues on to this day. Currently with 208 cases of TB as of August 31. So for last year's 2024 Department of Health target, we had 2,248 Next slide, please. 2,248 was our target, and we accomplished that by 259% with the new tools. Okay, next slide, please. So these are some health system building blocks that also improve access to care. So this is from the WHO. So if you have good health service delivery, an adequate health workforce, the proper technology, it improves your access to health equity and care. And one day also, we would like to focus also on social protection of patients with TB. Next slide, please. So we brought point of care testing to the people. So instead of waiting for people to come to the clinic or to come to us, what we did was we brought the services to the people through the ultra portable X-ray, the artificial intelligence, and the mobile point of care testing device, or the TrueNat. Next slide, please. So we encountered a lot of logistical challenges, as I mentioned earlier. This is us carrying around $100,000 worth of equipment through 1 kilometer of the island. So when it's low tide, you have to go to the other side of this island to get to the boat. So imagine our staff were carrying thousands of dollars worth of equipment across a kilometer of sand. And this was actually very scary for us because at the end of this, when we took the boat, we actually got caught in a rainstorm, as you can see in the next slide. We're still laughing in this picture because it was still the start of the rainstorm, but as it progressed and progressed, our boat ride took us actually almost 4 hours with the mayor and the Coast Guard asking where the heck we were. Next slide, please. So another way to bridge your health equity is also to incorporate not just the AI, we also incorporated our patient registration into the social health insurance program called PhilHealth. So we did this by becoming one of the first in Central Visayas to include electronic medical records. So next slide, please. So we use digital health to enhance healthcare access. So here we are in an islet barangay, about 2 hours from Bantayan Island. And as you can see in this slide, we have laptops with us because we're also using the Starlink device to get internet and to register patients so that we're not wasting time when we go into a community. We do a one-stop shop with patient registration, screening with the AI, and also treatment and confirmatory testing with the sputum test. Next slide, please. So this is an example of the ultra-portable chest X-ray with your artificial intelligence reading. So we have a patient here who will be X-rayed, as you can see on the very left. We just need them to take off their shirt. For women, you don't need to take off your shirt. You just need to take off your underwire bra, if possible. And then you get screened. In about 10 to 20 seconds, we have a result here. As you can see in this patient, it shows opacities with a presumptive score of 0.89 for tuberculosis. So any score with the AI, if 0.5 and above, would be susceptible or presumptive for TB. You would still need to follow guidelines, of course, and interview the patient. You also need to check for symptoms and also need to do the confirmatory testing just to make sure that the patient actually has tuberculosis. Next slide, please. So I just wanted to show here our point of care testing called the TrueNat, where you can do on-the-spot sputum testing, which will show either drug susceptible and drug resistant TB. As with all our tuberculosis patients, we also screen with our rapid diagnostic test for HIV on the spot because, as we've seen, some patients with TB also have HIV and vice versa. Next slide. At the same time, we also offer on-the-spot drug-susceptible tuberculosis treatment and counseling, as well as TB preventive treatment for their family members. Because as we noticed in the island, that one TB case could spread TB to the rest of the family. And it might not be this month. It could take years for the other family members to receive or to get tuberculosis. So encouraging also treatment and TB preventive therapy is also good, and it's a good way to curb the spread of tuberculosis in the island. And these medicines that you see here, some are donations, but most of them was purchased by the local government unit. So our next slide here shows our one-stop shop approach where when we go into a community, we don't just focus on just tuberculosis. We bundle the services with health registration, dental services, family planning services, women's health, immunization, and free medical consultations and treatment, because we've seen a better reception from the community when we go in there and bundle all the services together, because it makes it more convenient for the people who live in that community. Next slide, please. So I just wanted to show the TB case detection rate in the island from 2019 to 2024. As you can see, in 2019 to 2021, very, very low case detection rate. As I mentioned before, we were only screening about 200 patients a year at that point. And in 2022, you can see an increase of the case detection rate because of the new tools. So next slide. Yeah, you can click the next slide. And the other one, yes. So in 2024, 99% case detection rate because of having these tools bundled together. Next slide. So I wanted to show the TB case notification rate in Bantayan, Cebu. If you click on the next, the national baseline is 379 per 100,000. And as you can see, in 2022, 2023, and 2024, we actually surpassed that because of having AI and point of care testing available. So next slide, please. The tools are good, but having ordinances or having policy to back it up is what makes these tools stronger. So last year in 2024, with my consultation, the mayor and the Sangguniang Bayan, or the council members, enacted an ordinance establishing a comprehensive and sustainable response and commitment to eliminate tuberculosis in the municipality of Bantayan, Cebu, and appropriating funds thereof. Because if we don't have our own local funding, there will be no health programs, especially for TB. So you also need to have an ordinance to back up your technology. Next slide. We also got sustainable local funding through our PhilHealth program. And as last year, we were one of the top in the country out of all the municipalities. So in total, from 2023 to present time, the municipality of Bantayan, Cebu has raised around 22 million pesos. Next slide, please. We also did a lot of international collaboration. So as you can see on the very left side of the picture, that is Dr. Salman Khashoggi of Harvard University. And one of my mentors, he is also with Partners in Health with Michael Wilson on the right, and they are focusing on TB-free island, working in the Philippines currently for their TB-free island initiatives in the country. Next slide, please. So from clinic to community, you can't have patients just go to the clinic, and you can't expect patients to go there all the time. So sometimes you have to bring the clinic to the community. And by bringing the services such as AI and point of care testing to those in the community, people are able to access care, and then you're able to also break the barriers to healthcare access as well. Next slide, please. So this picture means a lot to me. This is a picture of Joseph. This was taken with his consent. This was back in 2022 when the community health workers actually were encouraging me to visit him. They really thought he was for hospice care. He was 23 years old at this time, and at this time we did not know his diagnosis. So with the tools, with the point of care testing tools, we were able to take his labs on the spot, and we determined that he had Pott's disease, or TB of the bone. And because of this technology and because of these tools, we're able to find the missing cases of tuberculosis, and we're able to save lives. And this is his picture on the very right side. That's his current profile photo on his Facebook. 3 years later, we were able to help treat and cure this patient. And I'm super grateful for the technology such as your AI to be able to save lives. Because at the end of the day, I did not become a doctor to become rich. I became a doctor to help people. And with technology, we can already do this in real time. So I'm really grateful for the companies that helped with these programs, and also the local government units that allowed access to these programs for their residents. Sorry, next slide, please. So I just wanted to thank our partners here, Stop TB Partnership, USAID, and the rest of the partners who have helped me in Bantayan Island and are continuing with this program to this day. Madamo nga salamat sa aton tanan. We need to remember that this is Joseph here. This was a few months ago, 2 months ago, our picture together. So we need to remember to commit, invest, and deliver, because the tools are important, but we also need active participation and active encouragement for advocates. Thank you.
Thank you very much for your presentation. Really appreciate the fascinating experience, and one that is very much, so it doesn't, okay. I thought it would move. No, okay. Okay. So I wonder if we have any questions online. Okay, so just for clarification, the AI components of the chest X-ray is a standard X-ray that is read in pretty much real time, I understand, and allows the identification of signs of TBC with high, with what I presume is a high levels of predictive value. Is that correct?
Yes, so we have the ultra portable X-ray, and then it feeds into a laptop with the AI. So it will have like the digital X-ray reading, and then it will have the overlay of the AI on top, which is using algorithms to check if it's tuberculosis or not.
Yes. And are they so what are the subsequent tests that are administered for the confirmation of the TBC in your setting?
Yeah, so in our setting, we have two devices. So we have the TrueNat, which checks for the sputum on the spot. And then we also have the Gene Expert machine, which is in our lab. So for example, the TrueNat can read about 7 to 8 samples per day, because it takes about 45 minutes to an hour per sputum sample. So in case we have more than 8 patients that day, what we do is we put the sputum, we collect it, put in ice bucket, and then we send it to our Gene Expert in the lab, so that we're not wasting any time. Yes.
And the Gene Expert in the lab, I mean, what does, I mean, what's the procedure for its detection of?
Yes. So it detects, it's a PCR, so it detects for drug resistant and drug susceptible TB. So similar to the TrueNat. But the thing with the Gene Expert is it can run multiple samples in one time.
Okay.
Yes.
And so in the first test, the sputum test, I mean, positives are then submitted to the gene assessment, or?
Oh yeah, so when you do the TrueNat, it's actually checks for if it's TB first, and then if it's drug resistant or not. So no need to send it again to the Gene Expert unless there's some sort of error or some sort of issue with that first test.
Okay. And so are you also responsible for the administration of medication then?
Yes, so we are our staff, so we have doctors who are trained by the Department of Health to administer tuberculosis medication. And we also have nurses who are trained TB nurses as well. So usually our TB nurses are trained also in HIV, provider-initiated counseling and therapy. So usually our nurses also do the HIV testing as well.
And so last question, because otherwise it is American. So do you have so do you also your team does direct observed therapy?
Yes. Yes, so we do TB dots, or the drug directly observed therapy. Yes. Yes, that is currently the protocol right now. And actually our barangay health workers, or the community health workers, also assist in that, because with our ordinance they also receive an incentive for every patient that gets the complete treatment. So that is also in the ordinance. So for example, if you're a barangay health worker and you have 10 patients that needs treatment, you'll receive an incentive or a bonus for those patients who receive treatment, because our community health workers are also volunteers. So
let me check if there's any questions online.
You have any questions? Yes.
Really fascinating work and achievements. I am curious about after this one-stop shop approach, and I think it's really impressive all the improvements that are being made in active case finding. But then when patients have to access treatment for 6 months,
Yes.
or however long, I'm curious if you can speak to how this approach has led to improvements in treatment, or if there are so major issues with TB being detected, but then maybe patients not being able to access or complete their full course.
Yeah, I understand this because actually this was an issue with other local government units. That's why we increased our coverage with our PhilHealth, our social health insurance. We made sure to get money from that, and also from our TB Dots program. There's also a claim that we can receive, so that we never run out of TB meds, because that is the issue when you have mass screening programs. Sometimes you screen and you screen, but then you're not treating people and there's a backlog. So far in Bantayan, there's no backlog. People are getting treatment in real time because of the additional local government financing, or the local health financing that we also have. So again, like what I mentioned before, it's nice to have the technology, but if you don't have the policy and the health financing to also back it up, then it is lacking. So that was a very good question. Thank you. Did that answer?
Yeah, there's a question in the chat.
Okay, how did the patients refill the medication? So actually our medications, we have purchased by the local government unit our medications. So what the patient has to do, if they can come to the health center, they can get their medications there. But usually we have patients that are in the smaller islets. So what happens is the barangay or the community health worker picks up their medication for the week and then dispenses that medication to the patient every day. So that's what usually happens in our setting. Or sometimes we have patients who are disabled, and the same thing happens. The community health worker or the community nurse will pick up their medication and dispense it to the patient at their residence. Okay, how did you first start bringing these technologies? It wasn't me, it was USAID who brought the technologies to the Philippines. And we were just part of a pilot program called the Introducing New Tools Project. So when USAID came to us and said, hey, you are chosen as one of the pilot sites, we didn't even hesitate for a second. We just said, yes, we will take it, even though it's typhoon season. We will take the tools because we know that being chosen as a pilot is a really, really big opportunity. So that's how we started, but we continued to do this program through the help of the Philippine Department of Health. We actually, the tools were donated to them. So instead of letting the tools just sit in a warehouse, we actually borrowed the tools from the Department of Health for another 2 years. And then finally this year, the Global Fund gave us our own ultra-portable X-ray with AI. And MolBio, the makers of the TrueNat, let us borrow their TrueNat machine. They've let us borrow it for almost 2 years now. So with this collaboration, this is how we brought these tools to the island, and hopefully to continue on. Okay. Yes, okay. So has the success of this program led to other parts of the country? Actually, Dr. Kishabji and Partners in Health are also working in Guimaras Island. So it's called the TB-Free Island Initiative. It was supposed to be under USAID TB Swift, but as we know, USAID is no longer in existence now. So Partners in Health actually is the one fully supporting that program with the Philippine Tuberculosis Society. And this year, so maybe in 2 weeks, there will be an X-ray, ultra-portable X-ray delivered by Min X-ray and Cure AI to Daan Bantayan. Daan Bantayan is on the mainland Cebu, actually affected by the earthquake right now. So they will be receiving a new set of tools in 2 weeks. So actually what we want to do is deploy the tools to the earthquake-stricken areas to screen for not just TB, but other respiratory illnesses as well. What's your plan in sustaining this initiative? Again, I encourage all local government units in the Philippines, especially to capture their PhilHealth claims. So PhilHealth is actually part of the Filipino coverage for health insurance. Every taxpayer pays into the system. The issue is a lot of local government units are not well versed in electronic medical records or electronic health records or technology. So by going in, there's actually a few companies helping local government units help capture these claims, because right now there is a technology divide where some local government units are not understanding how to use the online claim system or how to use the electronic health record system. So there is local sustainable health financing available. It's just a matter of access to this at this point. And I think there are a few consultants that are coming in and assisting with this. Oh, can you tell us more about the struggles? Oh, the struggles logistically. First of all, when you go from a smaller, the main island to the smaller islet, you have to really go with the tides. So if it's high tide at 3 a.m., you go at 3 a.m. There's no like, why do I have to wake up this early? It's like you just have to go because that's the time that the tide is high. And if the tide is going low, and sometimes you just get stuck in the island, you have to sleep there until the high tide again. So those are the logistical issues. Another issue is the staff. At first, the staff were kind of like hesitant to be trained because this is thousands of US dollars worth of equipment, and just being scared of like possibly like be the one breaking the device was scary. But over time, they built a lot of confidence in it because we trusted each other to get the work done. And also the community was at first scared. So when I moved to Bantayan in 2021, a lot of people still believed in witchcraft. A lot of people thought that tuberculosis was because of bad spirits. They did not think it was a bacteria. So before, when people had TB, they thought that person is going to die. They thought this person was nabarang or had a spell over them. But having these tools more accessible, the patients can actually see their x-ray. We can explain like, look, you have this opacity here. That's the bacteria in your lungs. Then patients are understanding and they're becoming more health literate. They're understanding why they have TB and that TB is a curable disease. So those are some of the, oh wow, okay, struggles, and then especially dedication. Cure AI too. How often have you encountered? Yes, okay. So sometimes you have patients who are smokers. And if, for example, if you have a patient that's been smoking for like 30 years, sometimes it'll show up as TB when it's actually lung cancer, okay, or a lung mass. So using the AI is good for rapid screening, but you still need to use your clinical eye. You still need confirmatory testing. And of course, you still need a radiologist to confirm if the patient actually has tuberculosis, especially if you're on the fence. So with the current Philippine Food and Drug Administration local guidelines for licensing, your ultra-portable x-ray has to be licensed to a health facility that does x-rays. And you need to have also a radiologist, radiographer on board who is licensed by the Philippines as well. So there are some technical and there are some regulatory things that go into this as well. So as you can see, the AI is good for rapid screening, but at the end of the day, you still need confirmatory tests to make sure that you are actually treating the patient, because you don't want to treat a patient for something that they don't have. Okay, let's see. Did you encounter resistance? Yes, actually, when we first, maybe our first ACFs in the islets, people were like, what is this construction? They were kind of scared. And at first, we were only screening the patients who we thought had TB. So meaning they had a cough for like 2 weeks, they had weight loss. So at first, we were just screening those patients. But over time, like even now, we're screening even asymptomatic patients. Because what we found is that there is a lot of cases now of subclinical TB or TB in patients that don't have any symptoms. So now we're making it as something part of their yearly health screening and something that they shouldn't be scared about or ashamed of. What I started doing also was I would get the x-ray before everyone else so that they can see that, okay, the doctor and the other health workers also got the x-ray, so it's not scary. Okay, we also had some politicians and some other local celebrities, I guess, get the x-ray also so that people wouldn't get scared. How did the community perceive or respond? So I think I mentioned this earlier. It took some time. So in 2022, a lot of people were still against it. They're like, I don't have TB, and they were fighting us, or they were ashamed because there's still a lot of stigma to TB and HIV. But now, 3 years later, people think it's a normal part of their health routine. So now it's considered okay to get screened and something that they shouldn't be scared of because we have the treatment and the technology. And is this initiative still ongoing right now? Yes, it's still ongoing. And we're planning to scale up to other parts of the Philippines. So there's actually a lot of different players in the Philippines who are also using these technologies. And we hope that this technology isn't just something that's novel, it becomes something routine and embedded in the clinical practice guidelines, especially for TB. So that's one of our hopes. And in 2 weeks from now, we will be having the Stop TB Partnership board meeting in Manila. So we hope to have more discussions with everyone who is involved at the global level and at the local level for TB as well. Okay, and then any other questions? Are medical students to pursue primary health? Okay, yeah, so I also teach part-time at Cebu Doctors Medical School. And what I tell my students now is that becoming a doctor, you don't just have to do your specialty and then just be in the hospital or in the clinic your whole time. You can do that, but you can also still engage the community by choosing public health or choosing to be a primary healthcare doctor. In the Philippines, actually, we're lacking a lot of doctors, especially in the government. So if this is something that is interesting to your students, you should make them pursue it. So when I used to work as a government physician, it was very, very exciting. You not only deal with TB, you also kind of deal with kind of CSI cases. You also deal with death certificates. You deal with your senior citizens, non-communicable diseases. There's a lot of variety there, especially if someone is still unsure about their field or if they're interested more in public health and community medicine. You can treat not just one person, you can actually treat a community by doing or implementing health programs. So if medical students are interested in this, they can email me or we can discuss it more also.
Any questions?
Any other
I think
questions?
that's maybe it.
Okay, so I would have one. I mean, how in terms of evaluation? I mean, also, I mean, this is something that takes place as part of the initiative of the Center for Research in Health System Performance. So I think that the information about how you have been able to work on an evaluation of the initiative and what yeah, I can imagine that it must not be an easy environment for conducting not just even evaluation, not to speak of research or so your experience in translating this into outputs that can help others make sense of the initiative.
Yeah, that's actually something I'm trying to work on now. So with the initial data collection, I saw before in Bantayan, they collect the data in paper still. So they have these books that they collect. What we saw historically in the past is that they would use one book for 5 years of TB active case finding. And then starting 2022, they're finally using one book per year, which is good. So that's one of the limitations of the data. There's still a lot of paper and pencil going on. Another thing that we're kind of encountering that we want to, I guess, work on in the future is to put these into your electronic records. So the Philippines has something called the ITIS, or the Integrated TB Surveillance System, but there's still a lot of issues with it that I think the national government is still trying to work on, because sometimes some of the cases there don't match the paper record and vice versa. So with evaluation, actually, it needs, I guess, more targeted approach, because a lot of the data is still historically on paper, and then some are on different Excel files, etc. So I've only been able to actually get a better grasp of the data when I started to be the one collecting the data when we did the New Tools project with USAID. Yeah, so.
And did they also contribute any resources to help you, disseminate the impact of the intervention?
Yeah, so USAID at the time really helped us by letting us borrow the tools for a significant amount of time. But not only that, they also helped us with training the staff and also mentoring, because like what I mentioned before, there was a lot of issues with people accepting the technology. So that's how they helped. And to this day, the previous staff at FHI's 360 still mentor me and encourage me to actually do more research into this and possibly evaluation into the program as well.
Do we have any more questions?
No, we're
or here? Well, I can tell you that these. You have more.
One thought that came up. You mentioned social protection.
Yeah.
As something that eventually would be great to have for patients. And I'm curious what you think that should look like.
Yeah. Actually, when someone has TB, they don't just lose 1 week of work. Sometimes they lose 6 months. Sometimes they lose work for a year or more. Especially with the case of my patient, Joseph, who had POTS disease. He actually was not able to work for about 4 years because of the significant disability that he had because of his spine injury. So when we're talking about social protection, this was mentioned at the union conference last year as well. We also need to start thinking about patients' livelihood, because sometimes the 6 months is not enough. It treats them, yes, but then sometimes they need additional assistance into going back into the workplace, especially with patients that have TB of the bone or other extrapulmonary tuberculosis diagnosis, because they also have that stigma attached. So I guess how this would work is to have some sort of maybe a stipend program or something like that that will help them get back into livelihood. In Bantayan, most people are fisher folks. So maybe helping them get back into that system somehow. I don't know exactly how that would look like right now, but maybe someday I can talk to more policymakers and health financing and determine that as well.
Well, thank you very much for the presentation. I can tell you it's been one of the most successful seminars we've had in terms of engagement. So certainly your talk has raised a huge interest. We're very grateful that you find the time to come to here and share your experiences. And I would like to, please join me in thanking so much for the presentation. And this has been recorded, so I will be available on our website for general use. So thanks very much for joining, everybody, and see you in our next seminar. Thanks.